talking about some reasonably high-flying scientific insights, but maybe step back a moment. And Jonathan, just before we depart into more advanced disease, sort of diagnosis and management, in the early diagnosis of melanoma, of course, there's features that people need to be mindful of. I mean, tumor thickness, of course, but ulceration continues to be this kind of intriguing feature of melanoma for its prognostic significance, but maybe even pointing to the therapy. So just maybe for this audience, just a quick, recheck on where we are in sort of, features of melanoma at the time of initial diagnosis.
Yeah, of course. So with, obviously, we look at the most important features for us are ulceration and Breslow depth, and that guides us as surgical oncologists for treatment of the melanoma. Of course, if a melanoma is ulcerated, we're going to go ahead and likely do a sentinel lymph node biopsy if the patient is an adequate candidate for general anesthesia and a sentinel lymph node biopsy. And for us at Moffitt Cancer Center, we do sentinel lymph node biopsies for any melanoma that's greater than 0.76 millimeters in depth. So those are the most important prognostic factors. And then you have other prognostic factors like microsatellitosis. They're a little less common than ulceration, and that also will portend a worse prognosis and push us into doing more appropriate surgeries like sentinel lymph node biopsies rather than just wide excisions alone to look for nodal metastases.
Can you comment on TILs? So tumor-infiltrating lymphocytes and lymphovascular invasion and age of the patient. How do you incorporate those factors?
In my practice, age doesn't really play much of a role in who I take to the OR for a wide excision versus wide excision sentinel lymph node biopsy if all other factors are equal, meaning Breslow depth is appropriate and/or ulceration. Tumor-infiltrating lymphocytes I don't really use as a factor to influence my wide excision versus wide excision and sentinel lymph node. And angiolymphatic invasion, if it's present, that will push me more towards a sentinel lymph node biopsy. But that usually goes along with a high mitotic rate and likely ulceration in the primary melanoma as well.
Mm-hmm. So Jeff, there's this provocative data comes even from the interferon realm, a little bit even with adjuvant ipilimumab, that ulcerated tumors then taken into the adjuvant therapy context seem to maybe have a different outcome. What do you think accounts for that? I mean, I feel like we still have relatively little insight into what kind of the unique biology is of an ulcerated melanoma.
Well, ulceration to me would imply a certain degree of aggressiveness, which you would think would be and is a negative prognostic factor. Those are probably the highly mutated tumors, and I would suspect, again, there's this interesting association of that mutation load with doing well with immunotherapy. Probably wouldn't apply, for example, as much to targeted therapy or chemotherapy, but I would say those tumors are probably going to be amenable to immunologic treatment. However, your point's well taken. I don't think in the studies that are ongoing that mutational load will be assessed as part of, for example, the study in EORTC where they're treating in the adjuvant mode ulcerated early stage melanomas, and they tend to have, they're bad actors. If you have a 2 millimeter lesion that's ulcerated, as John will tell you, and has 8 mitoses per high-powered field, you can bet that's going to be someone who relapses within 2 years. I bet they have that high mutational load. Those are the people you want to put on adjuvant immunotherapy.
And I might just make a quick comment also to note that I think there's growing evidence coming out of the clinic and from translational space to say that we're learning more about what that biology is that drives ulceration surrounding gene expression. Mm-hmm. And there are multiple diagnostic tests that are kind of questionably useful at this point, but I think are coming. And I think it's worth noting that a future paradigm likely will include some aspect of gene expression in the adjuvant setting to define aggressiveness.